nervous. Don't be nervous. Like, I just don't seem to get, like, if I have practice, I don't seem to get enough marks. So I'm like so worried now. How am I going to clear it?
What is the scoring like? What's the passing that you need?
65%, so you need to get a B in all.
Hello?
Okay.
Hi. Oh, hi.
Hi.
How are you feeling now?
Hang on, I tried to go in. Thanks for calling me.
Are you there? Hi.
Hello.
Hi.
I'm not on my phone, so I'm not sure if this is working. I just turn off the phone and then see what happens, okay?
Okay, that's all right.
Hi, I think it worked.
Okay, that's great.
I tried to be part of it as long as I can, okay?
Okay.
Thank you. I switched off my microphone again.
Okay, it's not working only. आप start मत करो आप computer. अरे यार. Hello.
Hello.
Hello?
Hi, everybody there?
Yep.
Okay, great. So once again,
Yeah.
I'm just trying to send one file to Komal. So looks like it's only 8 of us again today. Right. Komal, can you hear us? Komal, are you there? Okay. Is your mic on silent or mute? Okay, superb. So who's talking today?
Yeah, sure.
Perfect. So we can start then. We were doing last time. We were doing this 2005 to 2009, which I've just sent. So we can start from there.
Which page we are on?
Smartha, we were going to do all right from the beginning, right?
I don't know, up to you all.
Okay.
We can go from where we started there. But yeah, if everyone's here and everyone's new, then we can repeat the questions.
Okay, Komal, how is that? Because initially, if you look at the questions, so there are not a lot of them with. I mean, they're not very good recalls. So shall we? In that case, shall we start from the number? Hmm, shall we start from the case 60-year-old lady with abdominal surgery on morphine analgesia?
Yeah.
Okay.
Which page is that on?
On my side, it's on page 2. First case. Did you find it?
Are we starting from the first?
This one. The one which I've just posted right now. Shall we start from here?
Okay. I'm just trying to find the question.
Okay.
Yeah, got it.
Okay.
Yeah, just a second.
Sure.
Okay, so case 3. Everyone can hear me?
Yeah.
Yep.
Yeah, okay. Case 3. Mid-60s female who had upper left lobe resection 1 day ago. Chest strain C2. Question 1. How would you assess sitting on the side of the bed, high supported sitting, right side lying, or supine? No, you are reading something else. Really?
Yeah,
Sorry?
It's different.
It's different.
Yeah.
It's
Which
different.
one is this one? Which one is, which case we do? Is the paper is different? Oh, sorry. I thought, oh, sorry. I'm just reading from the paper. Sorry.
Correct. No. Tulsi, what I posted, that's the one, right?
Yes, that's the one. Yeah.
Okay.
Sorry. So are you going to post Poonam?
Yeah, I can post it. No worries.
Okay. Okay, sorry, I'll start again.
Okay.
Case 60-year-old lady having abdominal surgery on morphine analgesia, X-ray showing right middle lobe opacity. What is the risk factor for pulmonary complication? Lower abdominal surgery, B. Upper abdominal surgery, C. Thoracic surgery, and D. Age greater than 60.
Don't you think like we had done the similar question in the previous sessions?
Yeah, we have done this, but we left it, because we thought that a lot of questions on this paper were bad recalls, so we just left it at that time. Now because Komal is here and we have new people, maybe they have a solution to it. So what I'll do is I'll keep this question aside and I'll put it on Facebook.
You know what I feel? Sorry, guys. There is this a crop file.
Yep.
Okay, in crop file, I had read somewhere. Just a moment, I'm just trying to find it out.
Okay.
There is a reference that I think upper abdominal surgery causes inhibition of diaphragm and all. Just a moment, and this answer is there in PNP also.
Okay.
Can you? Guys, this is a case of colectomy or any like just a surgery, right?
Yeah, it's just a surgery.
See, I have a reference saying that if you open your crop file, page 92,
Okay,
page 90.
I was just reading that a little while back. Page 92 on the crop file, right? Thoracic surgery. Hello?
Yes.
Okay. Where is it? Less
See, there
But
is
what
a
confuses
diagram.
me is, sorry, but what confuses me is that it's saying explicitly abdominal surgery and not thoracic.
No, when you read the there is this heading is I'll tell you the heading of that is surgery. Okay, the first one is colorectal conditions. So just see crop page -90, page 90. So if you go through crop file page 90, they have written that after upper abdominal surgery, vital capacity and diaphragmatic motion have been demonstrated to be markedly reduced.
Okay, after upper abdominal surgery, vital capacity and diaphragmatic motion have been demonstrated to be markedly reduced for 1 week. Abdominal muscle activity is impaired, particularly on the first post-op day. Okay, so that would be upper abdominal surgery. That means.
I feel, yeah, likely to be upper abdominal surgery.
Okay.
Could you tell the page number, please?
Yeah.
Okay.
There's this chapter on surgery for adults in PNP. So we can check out in that also.
Okay.
Okay, because if you consider age, in PNP, it is okay. Guys, in PNP, have they given any age which is prone to develop respiratory complications? Okay, yes, at approximately 65 years of age. In PNP, that's 65.
Okay. Yes, age is also one factor, right? We were discussing the last time round. Age is a factor, but it's, the older is
More than 65.
more than 65. That's right. So we are looking at PNP, right? right now?
Yeah, you can get anything in PNP. Leona, it's in Australia. Under abdominal surgery, a colorectal surgery.
Komal, is the chapter which did you say in PNP?
Surgery for adults.
Okay.
But for me, I would go for upper abdominal surgery
Mm-hmm.
more prominent in this case.
Okay. 377.
Because thoracic surgery is out of question. Okay, age should be above 65 years according to PNP.
Yeah.
Lower abdominal won't cause so much of problem, I feel, because it's away from the diaphragm and away from that. So I feel upper abdominal, as I have seen this, it decreases the vital capacity and this. So I feel upper abdominal surgery goes more for this.
You know why I was getting confused between upper and lower abdominal was because you see, even if there is a lower abdominal incision, it will still affect your breathing muscles indirectly. That's what I was thinking. But now because I saw the reference, I think I would also be more comfortable with the upper abdominal surgery as the answer. Yeah. So there is a topic on incision and sutures in page 383.
Leona, if we can put this question on Facebook actually.
Yep, I can do that.
Last time you guys didn't post any questions on Facebook, no?
No, only 2 or 3.
Oh, you did?
I did only 2 or 3, not many. Okay, so let me just copy this question and put it on Facebook. Okay, so we go on to the next question.
Guys, on what question are we?
This one?
Okay. So what about the earlier ones, the fly chest and all?
Okay, because you see, if you look at it, the questions are not even formed correctly. Unless anybody has found anything, then we can put it there. But otherwise, the questions are not very good recalls.
Sorry. Can I go?
Yeah.
Yeah. What are the side effects of morphine? A. Respiratory depression. B. Hallucination. C. Nausea and vomiting. And D. All of above. Guys, there's a reference for all of the above. I think if you check morphine side effect, I just Google it.
Okay.
It's there in crop file also. I think I'm not sure about it.
I can check it. Yeah, it's sorry, it's morphine. The side effect is it's on page 29, strong opioid analgesic for moderate to severe pain. Onset of effect is about 10 to 60 minutes, and the thing is respiratory depression, hypotension, impairs gastrointestinal mobility होना चाहिए, and prolonged sedation in renal failure. Did you guys find it?
Yeah.
Yes.
So do you guys think we should just go with the with respiratory depression only, or we should take D still?
Okay. Heli, you searched, right? Okay, what's there in
Okay.
sorry. Yes, sorry.
Just a second. Because there's so many side effects, like this, they've given less common because of overdose and all that. I'll just tell you 1 second.
Do people get hallucinations with morphine? IPS.
Sorry, guys.
So,
Could I just say, I'm still thinking about the 60-year-old lady and her surgery. I've just found something in the thorax BMJ, and it's saying that, where was it? That indeed it has been shown that the incidence of significant respiratory muscle dysfunction after lower abdominal surgery is very low, 2 to 5%, while that of upper abdominal surgery may approach 20 to 40.
Great. Leona. Awesome.
I can.
Right documentation is also there. Guys, I'm
Google
checking
page.
AustraliaPrescriber.com. There's a magazine on it. IPL surgical page 4.
I'm sorry? What? Oh, okay.
We go with all of the above then.
Okay, I think that makes
Really?
sense.
Heli,
Yeah,
are you confident?
yeah.
So-
I found that also, that hallucination and nausea and vomiting comes with that. So I think it's all of above.
Really, but you found it in ILP.
No, I just Google it, morphine side effects, and just let me check.
Oh, somebody's ILP.
No, this Tulsi has put.
Nancy, hallucination is not given. Nausea, vomiting, and respiratory depression is given. Hallucination is not given.
Tulsi, which ILP is it? The one with the 24 pages? That one?
Yes.
Okay.
This is the one, guys.
It's surgical.
2005.
It's
2009, right? ILP surgical 2000.
2009. 2009.
Okay, on I'm on already on page 9. It's the University of Queensland, that one, right? But I can see the implications of physiotherapy management and IV drip.
It's on page number 4, dear.
4. Okay.
Oh, it's an ILP 2009, not 2006, right?
2009.
So is it that adverse effect of narcotics include? Is that the one?
And previously they given in narcotics they include morphine.
Okay.
In the page number 2.
Guys, so there are ILP of different years.
No, ILP for different things. This ILP for surgical.
So there are ILP for different topics.
Yes, different topics. For surgical procedures and supplement.
So guys, can we go for
Yeah,
Yes.
we can go for.
next question?
1 second. Komal, did you study?
Yeah.
Did you study about the X-rays?
No.
Actually, I got something in my Skype about X-ray. I will post on the Facebook page.
Okay, thank you.
Can I go?
Yes, please.
Yeah. Uh, the right middle lobe opacity in the X-ray is consistent with diminished shadow of descending aorta, diminished shadow of right hemidiaphragm. Only two options?
Yep, that's right.
Okay, yeah. Guys, we had this type of question before as well, in which there was a mistake that it's a right middle lobe is when it's right middle lobe opacity, usually diminished shadow of right hemidiaphragm. I think it's given in the prayer and prasad. Have a look.
Let's have a look. Yeah.
Guys, in practice analysis, it was like right hard blurring of sharp right hard border.
I'm sorry?
Oh no. Yeah, because they're saying that note that the right hemidiaphragm is clearly visible as far as the vertical column. So it may be A.
Ellie, where are you? Like which page?
It's in the fourth edition, page number 33.
Under what section?
Uh, You know there's X-ray given.
Collapse
Yes.
of individual lobe.
Yeah, there's right middle of consolidation.
It's on page number 41, Mohan, in third edition.
It's
Yeah,
a.
I read that, but I couldn't find it.
Is it just look at the collapse of the individual lobes? That middle lobe, is that the one?
Yeah.
Okay.
Right. But it's middle lobe, it's not lower lobe, right?
उसके नीचे.
Yes.
Next one is lower.
Yeah, but in lower lobe it's given on lateral view, the oblique fissure moves backwards, and with increasing collapse, there is loss of definition of right hemidiaphragm as well as increased density overlying the lower dorsal vertebrae.
Hmm.
So that's a right lower lobe, right? It's not middle lobe.
Yeah. You're right.
I feel it's more with the descending aorta.
Yeah, I think it could be now that now I'm looking at the middle lobe. It could be actually the diminishing of the descending aorta.
Yeah, A, not B.
Yeah, because they say that the lower half of the major fissure moves forward, giving rise to triangular shadow visible behind the lower sternum.
Yep.
So can be Facebook, please.
Okay, I'll put it there. Surely. Okay, made a note. Page 41. Okay, I put the next question.
And that's missing two options. So maybe the third option is maybe the loss of right heart border. So we don't know about it.
Hmm. Okay.
Okay. Patients with exacerbation of COPD, X-ray showing right lobe opacity, taking medication by spacers, steroids, bronchodilator. What is the rationale for using spacers? A. To increase the deposition in the lung. B. Because it is cheap and increase compliance. C. To increase impaction of drug in the upper airway. And D. To increase gravitational sedimentation.
Can I post? If everybody's happy, can I post the next question?
Yes, Poonam.
Yeah, please.
Okay.
The opacity seen in the right lower lobe is consistent with diminished shadow of right heart border, B. Diminished shadow of descending aorta, C. Diminished shadow of right hemidiaphragm, and D. Shifting of trachea.
Opacity in the right lower lobe.
Guys, I would go with C here.
Particularly right
Same
hemidiaphragm.
PNP, yeah, PNP what we read is the same thing, right? They said that there is loss of definition of right diaphragm,
Hmm.
right diaphragm. So I go with C. With it's the right lower border here, lower lobe here. So we can go with that.
Answer should be the right hemidiaphragm.
Yes, that's what C.
It's left hemidiaphragm.
Is it?
No.
No,
That day we.
right?
That day we gone and we made the change ourselves from the left to the right.
Yes.
Because Komal,
Yes,
what
yes.
happened that day was that the C was written as diminished shadow of left hemidiaphragm, and then we all thought, and that was the only best answer, so we made the left to right.
Guys, and there is one more sentence. Right lower lobe collapse is the mirror image of left lower lobe collapse.
Okay.
Okay, so whatever we see on the right lower lobe is there on the left lower lobe also.
Okay. Okay.
That's given in prior and Prasad.
Yeah, same.
Guys, can I be? I'll just be back in 10 minutes. Sorry.
Okay. Okay. Shall I put the next question? That's what is the sign of infection? There is nothing given, so I'll move on to case 9.
Baby of smoking mother needs oxygen therapy. Why babies need oxygen therapy? A. Less number of surfactant. B. Restricted growth in XYZ stage of embryology. That's it. Not sure.
Uh,
Why they saying babies?
no, do you know something that there are some children who are born who are drug addicts? Do you know that?
Oh.
They're dependent on drugs because the mothers have claimed, oh, just before having the baby they've had a shot themselves. So when the baby is born, the child is already dependent on drugs, and they are very poor prognosis because you can't give drugs to a child and mostly they pass away.
Oh my God.
Yeah, it's quite sad actually. It's quite sad. Yeah.
Why do you want to take drugs before delivery?
Oh, you'd be surprised. There's so many people who even smoke while they're pregnant.
Anybody read that what I post on the group now before 10 minutes?
Yeah,
Effect of
I saw
smoking
you
on
posted
pregnancy.
something. I saw you posted something. Hang on.
It's related to this only, smoking.
Yeah. You posted something. Yeah,
They say
smoking during pregnancy.
adverse effect of smoking on baby.
Hmm. Okay. So it's what do you say the answer is for that?
It's not exactly, the option is not there. They say there is a chance of reduction of oxygen supply to the baby because of nicotine and carbon monoxide.
Okay.
And there is a
So what do we do with this question?
no, there is no option.
Oh, there's no option. Do you think we should move on then?
Yes.
Okay.
Female chronic smoker, chronic lung infection on antibiotics, feeling breathlessness. ABG has been done. Can't recall the value of ABG. Oh, sorry guys, just a second. Just pressed the wrong button. Sorry.
Oh, that's all right.
What will be the immediate management? Antibiotics and nebulizer. Antibiotics, oxygen therapy, nebulizer, oxygen therapy. That's it. antibiotics because they're already on antibiotics.
Yeah, maybe it's a mistake in typing or recalling.
Okay.
Maybe. It's just a possibility.
And oxygen therapy also, like if we can see the ABG, then and then I can go for oxygen therapy. Otherwise, antibiotics and nebulizer is fine.
I was thinking it is oxygen therapy
Hmm.
because again the same thing because they've already mentioned antibiotics.
Yeah, actually, but wouldn't you think that, okay, just thinking this way, wouldn't your nebulizer actually help to open up her airways and disperse the medication quickly?
Yes, usually.
Usually, right? So if let's
Yes.
say your A would have been only nebulizer, would you go with that? Or okay, let's say if A is nebulizer and C is oxygen therapy, which one would you pick?
That's again depend upon the ABG findings. If the O2, partial pressure of O2 is less, then we'll go for oxygen therapy. Is it or not?
Yeah,
We don't have ABG analysis.
yeah, that's right.
If the ABG is normal, why we need to go for oxygen therapy?
Yeah,
I'm not sure. I'm just,
that's true.
Because the patient is feeling breathlessness, so there be hypoxia. There may be hypoxia.
Yeah. So what do you want me to do?
not sure.
I can post it on Facebook and see. Let's see what people say. But they will be giving
All
their reasons
answers.
like us only.
No. See.
Sometimes we get more confused looking at the Facebook
Yes.
Oh yeah, definitely. You know that one question was there, the autogenic drainage with the soft cough, and the autogenic drainage with a hard cough. Remember there was a question like that, people. And we decided to go with the softer cough, but Dave is trying to prove his point on on Facebook that it has to be autogenic with strong cough. So exactly contradicting from what we guys thought, so it gets me very confused. Okay, shall I put the next question?
Yes.
Okay.
It's the same one, I think. Okay, patients. Is that a patient with exacerbation of COPD X-ray? Is that one?
Yep, that's the one.
Same one. Okay, patient with exacerbation of COPD X-ray showing right low propensity taking medication by steroid bronchodilator. What is the rationale for using spacer to increase the deposition in lung because it keep and influence compliance, to increase impaction of drug in upper airway, to increase gravitational sedimentation.
Everybody happy with A?
Yeah.
Okay, then I put the next question. It's already there, Helly. Yeah.
Yeah. The opacity seen in the right lower lobe is consistent with diminished shadow of right heart border, diminished shadow of descending aorta, diminished shadow of left semidiaphragm, and shifting of trachea.
Yep.
not the left side. So we changed it again.
No, we did. We didn't. We changed it for the last round, but I didn't change it for this round.
Yeah, same here. So what do we do?
So
Are we changing it?
yeah, you know what? Because just now Komal had mentioned that I'll read it
Oh,
out.
mirror image.
Yeah, the mirror image. So I think even if it's a right side or a left side hemidiaphragm, it doesn't make any difference.
Yeah.
Yeah? Okay. So I'll. The next question is what are the signs of infection? We leave it. Then I'll post the next one. Abdominal aortic aneurysm. That one. Oh, okay. There is nothing. So there are 3 questions. What are the risk factors for abdominal aortic aneurysm? What advice should be given for patients with abdominal aortic repair before discharge? And okay, why don't we do one thing? Let me just pose the question and we try to brainstorm ourselves.
I think that's what we decided last time.
Yep.
To learn the answers for all these questions.
Yes.
Is that how?
Yes.
Do you want me to do this as a topic?
Oh yeah, I think it's a great topic. It's a great topic.
Okay, I'll do it.
Okay.
And what about the second one? I can do that as well.
Okay, fine. So 1 second, let me open my my diary.
Because others, anyway, someone will have to do it.
Okay, I have it's on my this thing topics. So what was left was one moment. Um, so even your this thing was taken up. Your tumors was left. Heart failure was left. Lung fibrosis was left. Peripheral artery disease was left, and venous disease was left. Yeah, these were left.
So yeah, I'll take this one and give me any other topics as well.
Okay, no, you have to choose. I can't give you. We can't give you.
Yes. No, I mean just post it somewhere or just put it on the Skype and I'll choose one.
Okay, fine. I'll do that. I'll do that before when we end it. Yeah, today.
Yeah, but I'll surely find out the stuff for this.
Perfect. Okay. So we're looking about abdominal aortic aneurysm. Yeah. Page 419. Okay, so I've come across this on page 419 on Brian Prasad. Physiotherapy key points. So majority of patients presenting with abdominal aortic aneurysm are over 70 years old and varying degrees of atherosclerosis. Okay, then they also have issues with mobility and exercise tolerance. Okay, and early mobilizations within the patient capacity is important to avoid respiratory complications, and uh, then they may cause stretching of the recurrent laryngeal or phrenic nerve, and less commonly vertebral body erosions leading to back pain or spinal nerve compression.
Maybe for thoracic.
Yeah, I realized. I realized when I was reading. Okay. And approximately 90%, 95% of the abdominal aortic aneurysms occur below the level of renal arteries, and surgical repair therefore should not directly affect the blood supply to the kidneys. Okay. That's all. Nothing, I think it doesn't have a lot of detail given. Anything in the ILP for this one?
I'll find out and I'll tell you all.
Okay, fine. Okay, fine. We'll do that. Yep.
Uh, what position? What position in line increase gas exchange? Uh, there's two questions. Oh, so all are the questions.
Oh, all
What
are
does the
questions. Sorry.
you want me to read the question?
No, 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 no. But you know what? I think I have seen these questions before. What does JVP signify? Why
We did
musculoskeletal
it
problem?
last time.
Yeah, we've done it
We
last time.
decided to study. We decided to study on these as well
Okay, okay.
because
So,
I marked both of them in the same pattern.
okay. Okay.
I can find the answers for this as well next time.
Okay, sure.
35-year-old man with asthma, wheezy since birth with triggering agents including upper respiratory tract infection, exercise, dog hair and house dust mites, admitted to hospital today by his general medical practitioner because of worsening symptoms and difficulty taking his medication. Currently using 2-meter dose inhaler with spacer for the delivery of his medication. Salbutamol, Ventolin, a symptomimetic beta agonist, baclomethazine, dipropriate, Bicotide, persistent non-productive cough, expiratory wheeze, and labored breathing. Uh, just a second. Appears flushed and very anxious and is having difficulty completing sentences. Arterial blood gases on admission. O2 94. Partial pressure of O2 10 kPa. Partial pressure of CO2 4.1 kPa. pH 7.47. On examination, heart rate 100 beats per minute, temperature 37.8, respiratory rate 28 breaths per minute, shallow prolonged expiration, short gasping, inspiration. FEV1, FVC ratio 65%, auscultation, reduced breath sound throughout the lung fills with widespread expiratory wheeze. The patient's chest X-ray is likely to show evidence of A. Hyperinflation, B. Hypoinflation, C. An enlarged heart, and D. A mediastinal shift, and E. Signs of lobar collapse.
Okay, I'll put the next question then.
The patient's FEV1 FVC ratio indicates he has an obstructive airway pattern, a restrictive airway pattern, severe airway obstruction, and moderate airway obstruction.
If everybody's happy, shall I move on to the next one?
Yes.
Perfect.
What is the rationale for using spacer for the delivery of Bicotide in the patient's case? A. To increase intraarterial impaction in the larger airways, to reduce the possibility of oral candidiasis, and dystonia. C. Because 4 or 5 hubs of bicotide can be inserted into the spacer for each breath. D. Because a lower dose of bicotide can be used. E. Because a spacer makes it easier for the person to inhale at a fast inspiratory rate.
Everybody happy with that?
Yeah.
Okay, so I'll post the next question.
Bicotide has which of the following actions? A. It is an anti-inflammatory steroid. B. It decreases microvascular permeability. C. It decreases bronchial hyperactivity. And D. It inhibits the formation of inflammatory substances such as lymphocytes and eosinophils.
Were we the same people who were there last time?
Komal is new.
Apart from her?
Nobody. I think our group is more or less our group is like this. Esther was there. Esther is not here today.
Yeah. And then because we've discussed these questions already, if we are the same people.
Mm-hmm.
Sorry guys, I forgot to say E. All of the above are correct.
Yeah,
Oh.
that's the answer.
Okay. So yeah, actually you're right. So we have the question number 5 and question number 6. I have written as a thing that we'll discuss it next time.
Yeah.
So let me put that one straight away now.
Yeah.
Okay, which of the following is true with regard to the patient's inhaled medications? A. Particles between 5 to 10 IM are deposited in the small airways. B. Breath holding increases in arterial impaction of the particles. C. Gravitational sedimentation is time dependent. And D. Rapid inspiration increases the inarterial impaction of the particles. And E. Bronchodilation is mainly achieved in the fifth generation of the respiratory airways. Guys, what's this? I can't understand this. ER.
It's maybe
Right.
inertial.
Okay, inertial. Oh,
Yeah.
so what's that? Inertial infection. I don't know. First time I heard that.
I have listened to this term inertia in physics, but I don't know the meaning of this term over here.
Okay.
Hang on, let me 1 second. I can find out something. So definitely it has something to do with the physics term only. And when I'm looking at Google, it's saying it's a theoretical model of the simultaneous action of inertial impaction and gravitational forces on a particle moving in 3-dimensional circular bends. Deposition efficiencies are computed for 3 different idealization flow patterns, that's uniform, that's radically dependent, and parabolic. So
Yeah, fine. I found that.
yeah, it's also if you look at the medical dictionary, it's got a nice one. Wait a minute, I just posted for everybody. This one. That's a good explanation.
Okay. So what is the answer for this?
Okay, why don't we look at this thing? I was looking at this one. Inhalers. GHI. Regard to patients inhale medication. Would you say it's C, Tulsi? Any reference you found?
Because I read it prior, but I'm not getting the page. That it mentioned in prior the particle between 5 to 10 mm are deposited mainly in alveoli. So that should not be answered, right? Here it is given small airways. Then last one, I'm eliminating the options. Bronchodilation is mainly achieved in the fifth generation of respiration. It's not given like this. Bronchodilation can occur everywhere, not after fifth generation. So that should not be answered. And it is directly given somewhere. Gravitational sedimentation is time dependent. I'm searching the page number. Just a minute. So A and E is totally wrong. This should not be an answer.
Okay. A and B is wrong. Okay.
A and E is wrong. So we thought, and always when patient is taking any kind of drug, we will instruct them slowly inhale the drug, not fast inhalation.
So D is also out, right? Yeah.
D and B both are out because they both are, one is for holding, one for the rapid inspiration.
Okay.
Not getting the page, one page that clearly mention gravitational sedimentation is time dependent for the drug particle.
Okay.
The prior.
My God, how they are finding questions and they're making questions out of that. Yeah, they're picking up small lines from somewhere.
Hi, I'm back.
Hi. Shall we do one thing, Tulsi? If you
Yes.
find the reference and you
Yes,
just
yes, I definitely find it later and I will post here or at the end.
okay, sounds good, sounds good. And okay, who is this? Jaspreet.
What photo is this?
What position is in lying can increase cautious exchange?
Somebody just put it on the Facebook.
Oh
On
yeah. The questions were missing, right? It's with regards to that. I understood.
Shall we move on?
We could, yeah.
Yeah. 70-year-old obese man, history of smoking, 40 packs year, but these 10 years ago. Transferred to a medical ward from intensive care unit. Surgical repair of abdominal aortic aneurysm 4 days ago. Prolonged stay in ICU due to hemorrhage, hypoxemia, and bilateral lower lobe collapse. Now stable at rest. Afebrile. Uh, Deperinized. No evidence of sputum retention. Has not been out of the bed. His attachments are oxygen cyclical flow rate via Hudson mask, central venous patient intravenous line, patient control anesthesia with narcotic infusion, bore drain, indwelling catheter. From the following list, identify the most important element for the physiotherapist to assess or check prior to commencing any physiotherapy intervention for Mr. J. Abdominal GERD, breathing control, dizziness, headache, fluid balance, 2. Peripheral sensation, CVP, dyspnea level, or sleep breathing, 3. Blood loss from bore drain, CVP, breathing pattern, oximetry, 4. Fluid balance, arterial blood pressure, level of pain, pulse, 5. Intercostal catheter drainage, paradoxical breathing, loss of facial color, nausea. A. 1 and 2, B. 2 and 4, C. 3 and 5, D. 3 and 4, and E. 5 and 4.
I'm thinking that it's not necessary for the physio to know how much blood is losing from the drain, right? Would you say that?
Yeah, not really.
No, because the patient is abdominal aortic aneurysm and bore drain is there, so we have to look for that. I think
We have to look. Okay, fine. So,
because of in this condition.
okay. Three and four.
So how about 3 and 5?
Yeah, I was thinking the same actually because in between 4 and 5, I thought that it's more important for me to see his loss of facial color and nausea more
And also
than,
paradoxical breathing.
yeah, that's right, more than his level of pain is also important, but I think if he collapses on me, that would be the worst.
But like breathing pattern and in paradoxical breathing, like in both things we are checking his breathing pattern.
Sorry, oh yeah, in the 3 and correct, you're right.
3 and 5.
But then you also have in 5, sorry, you also have loss of facial color and nausea.
I think after we read aortic aneurysm, now we can able to answer this question.
I'm sorry.
Yeah, we have to read in detail aortic aneurysm, then only we can able to answer.
Yep, you're right. You're right.
Is it
Shall I post the next question then? I'll make a note of this one.
Komal Sanjay Facebook?
Okay.
Next question. From the following list, identify the most important element for physiotherapist to, to assess or check during physiotherapy intervention for Mr. J. Uh, First is BOG, fatigue score, headache, paradoxical breathing, dyspnea level, auscultation, loss of facial color, oximetry, arterial blood pressure. 3. Temperature, CVP, breathing control. 4. Force expiratory volume in 1 second, vital capacity, visual analog pain score. 5. Breathing pattern, dizziness, pulse, and sweating. So A, 1 and 3, B, 2 and 4, 5, C, 3 and 4, and D, 3 and 5.
Guys, and there's no fourth option is for sure, right? That
Yes.
is force expiratory volume. That I think that is the one. Because I'm
And
trying to figure out whether there's only one option with 4. No, there's two options with 4. Either 3 or 4 or 5 or 4.
Then I think I would go with 4 and 5. What do you think? Breathing pattern and dizziness and pulse and sweating.
Guys, is this the question from 2005? If it's from 2005, you already have the answers for these.
don't know. Have to check.
Can somebody check 2005?
Yes, I'm checking.
Is that the Miss Esther one? That one?
No.
Yeah.
Yes.
Okay. So
Yes, it is from the same question paper.
Oh, great. I just guessed it.
Let's see the answer.
No, this question is not there.
Yes, it is.
Is it there?
Yes.
Oh, okay.
Case number 2,
Where?
case, paper 1, case number 2.
Okay. Paper 1, case 2. So, do you know the page number?
No, it's the hard copy.
Okay. Because my case 2 is that 55-year-old female admitted with right middle lobe pneumonia. That one.
I think you are seeing the question, case number 4.
Tulsi,
Yes.
I can't find it. So, is it the one Miss Esther Cardio 2 moderator and answers? That one?
No, not that one.
Okay. Maybe later you just pass it to me. I'll,
Yes.
I'll ask you. Okay? Cool. So, what is the answer for this one?
For the previous one, question number 7, the answer is D.
Okay.
And for the
Third
next
and fourth. Second and fourth. Tulsi, I'm sure they must be giving the reasons also down. If you scroll down.
Yes, I'm posting it. Just a minute.
Thank you. Great. Is it D or B?
I'm just posting this answer.
Even I don't have the paper. Although I remember we
I will
downloaded it.
send you everything.
Yeah.
Thank you. Guys, if you're happy, shall I put the next question?
Oh no, I don't have the answer for this one. Is it B or D?
Okay, so for the 7th question is D, correct?
D for dog.
D for dog, and then the 8th question is B. And Tulsi has posted the reason also. Just see your Skype.
Yeah, okay.
Got it?
Yeah.
Okay.
Bronchial breathing may be heard in Mr. J because he has A. Upper airway obstruction, B. Pleural effusion, C. X-ray evidence of consolidation without obstruction from sputum, D. Respiratory depression, E. A pneumothorax.
Okay. If everybody's happy, shall I put the next one?
All of the following would help the physiotherapist recognize clinically that Mr. J has a post-operative chest infection except A. Restlessness and irritability, B. Abnormally raised temperature not otherwise explained, C. Decreased respiratory rate, D. Tachycardia, E. Increased amount of sputum.
Everybody happy with that?
Yeah. Which of the following factors are responsible for keeping Mr. J's alveoli open? One, lung. I just can't pronounce this. Sorry. Inertia. Yeah. Sorry. Lung inertia. Hysteresis. Three, interdependence. Four, surfactant. Five, carbon dioxide. So the answers may be A, 1 and 3, B, 2 and 4, C, 3 and 4, D, 1 and 5, and E, 2 and 3.
I didn't have the 13th question, by the way. Neither do I have the 14 and the 15 also I don't have.
Same here.
Yes, same here. Can I go to 12?
Yes, please.
Okay. If CVP line is used to monitor which of the following? A, right atrial pressure, B, left atrial pressure, C, pulmonary artery pressure, D, pulmonary capillary wedge pressure, and E, tubular venous pulse.
Yeah, Komal, I also can't find it. I found after that there's a case 9, which is 88-year-old male.
Sorry. It's my mistake. Sorry. Grace, you are right. The case 9.
Case.
I found 12.
Yes, I found 12.
Okay, so shall I post this one, the 9th question?
Yeah, that's fine. Uh, 88-year-old male, Mr. M, admitted to a medical ward following a history of feeling unwell for 3 days. Thinks he has a fever. He has been experiencing increasing breathlessness, moist cough, difficulty clearing sputum, past medical history COPD, chronic atrial fibrillation, ischemic heart disease with moderate impairment of left ventricular function, reflex esophagitis, and prostatism. Medication include prednisolone, Atrovent via lethal dose inhaler with spacer, Cotide, Propyl, Prazosin, oh my god, fusimide, Ventidine, aspirin, ABG on admission, 28% O2, pH 7.32, partial pressure of O2 60 mmHg, partial pressure of CO2 75 mmHg, and CO3 34. Is it a minus 34 ml? Looks like minus 34 ml. And then saturation of O2 30% on 28% oxygen via mercury mark. Other finding on admission, heart rate 85 beats per minute, blood pressure 100 over 60 mmHg, respiratory with 30 per minute of condition. Increased breath sound throughout widespread polyphonic wheeze and biphasal inspiratory cackles. Cough is weak and voice sounding, is sweaty, short of breath during conversation and orthopneic. He is very thin and extremely brave and has significant bruising on his arm and leg. Immediate medical management, intravenous hydrocortisone and antibiotics, Ventolin, Atrovent, saline given for 4 hourly via nebulizer, digoxin, and increased level of perindopril and fusimide and oxygen therapy. Oh my god. What's the question?
The question is the
What question?
Questions will start now.
No, the question is already there, right? Isn't it? Intermediate medical management. Oh, sorry, immediate medical management.
Is that the question?
No.
Oh, that's.
I guess the next one, 49, is the question.
Wait a minute.
Yes.
Yeah, okay.
The question is here now. Yeah, the question is regarding the ABG finding. 49, which of the following is an indication of Mr. M's acid-base disorder?
Yep, I
Yeah,
posted it.
Which of the following is an indication of Mr. M's acid-base disorder? A. Respiratory alkalosis with partial compensatory metabolic acidosis. B. Metabolic alkalosis with partial compensatory respiratory acidosis. C. Respiratory acidosis with partial compensatory metabolic alkalosis. And D. Metabolic acidosis with partial compensatory respiratory alkalosis.
Leona should be the one. Leona's topic. Okay, what I'm thinking is that the pH is 7.32. Isn't that falling within the normal?
No, normal is
7 point
0.35.
within 3. Oh yeah. So it's gone down. So it's become acidic.
Yeah, it, like from the gas pressure, we can say it's respiratory acidosis.
Hmm.
And
I don't know how you do this two-part thing. Do you all know how to do this two parts? Acidosis and alkalosis.
Yeah. So if it's below, let's say if it is within this pH is within the 7.35 to 4.5, then it's normal, right? It's compensated. Or is it uncompensated?
it's uncompensated.
So if the pH is normal, it becomes uncompensated, and then if it's falling less than 7.35, then it's acidosis. More than 7.45 is alkalosis. Okay, and
No, I understand that, but we never talk about both the components, anytime.
now
We always talk about only one thing, but this gives you both the
But
components.
when the initial there is respiratory acidosis, that means it is always compensated by the opposite group. Just remember that.
Oh, okay.
Don't remember much more things. Just simply, if metabolic alkalosis then compensated by respiratory acidosis. Totally
So just
opposite.
just find the correct one and then
correct
the
one,
opposite
then
one.
then the opposite one. Yeah.
Okay, got it. Okay. Nice.
okay, I put the next question.
Sorry, what's the answer for this class?
C.
Guys, there is a chart in crop file. Page number is page number 54, 55. Can you all see page number 54, 55 crop file?
Yeah.
In that they have given a chart.
Yes. Example 1.
No, example 2, acid-base compensation.
Is it 7.33 and then 49, that one?
No. Example 2 on 55 page.
Okay. 7.33 and then 32, 21, that one, right?
It's 7.29, then 7.33, 7.37.
Okay. Yeah. Okay.
So guys, when we saw this, okay, this same question. Guys, can anybody tell me the figure of HCO3? Okay, everybody is on that chart.
Yes.
Yep.
Okay, so let's see with this. The answer for this is respiratory acidosis, partial compensation, right?
Yep.
Okay, so let's see the figures out in this question and let's tally it.
Okay. Sounds good.
pH is 7.32.
Yeah, so that is pH is 7.32. Everybody is on respiratory acidosis, partial compensation, that line.
Yes.
Okay, so pH is 7.32, that is decreased.
Mm-hmm.
Yeah.
Okay, next PaCO2 is
Increase.
75 mm of Hg.
Yeah, so that is acidosis is increased. That is the arrow showing up.
Yes.
And how about HCO3?
It's 34 ml.
Oh, so that is also increased, right? So HCO3, the normal value is 22 to 26.
Yeah.
Yes.
So that is also
It is because of
Yep.
Yeah, because of compensation, right? So
No,
okay,
Okay. Yeah, good one. Good one. So we are sticking with C, right? Respiratory acidosis with partial compensatory metabolic alkalosis.
Yes.
Yeah? Okay. Okay. Proceed to the next question.
Okay. Which of the following statements about the mechanism of Mr. M's orthopnea are false? A. Orthopnea is due to an increase in pulmonary venous congestion. B. Abdominal content causes an increased mechanical load on the diaphragm. C. Reduced closing capacity results in VQ mismatching. D. Orthopnea is often associated with hemostasis. And E. All of the above are false.
To see any reference that it's D? Because I thought,
Right.
I thought when he's.
Prior,
I'm
yeah.
sorry. Go ahead, go ahead.
No, 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 first, because in prior it's given in orthopnea. Orthopnea means difficulty in breathing in supine position.
Yeah.
So at that time, obviously the abdomen, of the diaphragm is much higher, so it will compress the lungs and all contain. So it will increase the orthopnea. So first one, there is venous congestion. If there is venous congestion, that also increase orthopnea. And because of venous congestion, there is a levi extension. It will also further increase the orthopnea. But it's never mentioned anywhere that hemostasis causing it, because hemostasis is a blood in sputum. It is not related with orthopnea.
Oh, yeah. Okay, I see. My what I was doing was what is the cause of orthopnea? So I didn't go the other way around. Understood. Understood.
Tulsi, this must be in 2005 paper.
Okay, let me search it. Just
Since the above question was there, this must be 100%.
one. I posted it.
Thanks.
Oh, you posted it? Okay, thank you. I posted the next question.
Okay. The physiotherapists find that when Mr. M moves quickly from standing to the supine position, he experiences a breathlessness. Which of the following statements about possible cause of breathlessness are true? First, the effect of increased preload on the heart. 2. The effect of decreased preload on the heart. 3. The effect of increased right ventricular and diastolic volume. 4. The effect of fluid backing up in the lungs. And 5. The effect of increased ejection or fraction. So A is 1, 3 and 5. B is 1, 2 and A is 1, 3 and 4. B is 1, 2 and 5. C, B 4, 5. D 2 and 4. And E 1 and
Tulsi, the answer is A.
Yes, I posted it.
How can we the effect of increase of preload
No, second, no, third one. First, third, and fifth. Fourth one. First, third,
First, third, and fourth.
fourth.
Oh, I thought it's fourth, third, and fifth.
First, third, and fourth. Okay.
It's right because patient is in standing and going in supine position. So everything is correct.
Oh yes, I thought first, third, and fifth only. Sorry, I put it wrong. Perfect. I agree.
Given in one chapter, clear, very good explanation is given in cardiac rehabilitation and in chapter. Effect of positioning and mobilization. Chapter 13.
But this answer you posted from 2005, no?
Yes, yes, I posted from that, but I come across cardiac rehabilitation also they explain very well, and in this also.
Okay, I posted the next question.
Okay. Which of the following would be the most appropriate management strategy to assist airway clearance for Mr. M? Deep breathing, thoracic expansion exercise, B. ACPT, modified gravity assisted drainage positioning, C. Sustained maximal inspiration, percussion, D. Gravity assisted drainage positioning and shaking, E. Positive expiratory pressure mask and breathing control.
Tuesday, I'm sure this would be also 2005.
Yeah.
It's
Yes, I'm right.
B. It's B, right? Yeah.
Yes.
Guys, remember this. It's a general rule in Australia. They first always emphasize on ACPT. So whenever you see ACPT option, you should pick that.
Can I go next?
Yeah.
Yeah.
Yeah, just sorry. Regarding this question, yeah, if you see regarding this question, no, obviously, the first, okay, the first way breathing thoracic expansion is not an air clearance technique, so we rule that, okay. Sustained SIM, like maximal inspiration, that is also not a technique. Shaking can be technique, but I think it's not so. It's not. It's most of a passive thing. Okay, active like ACPT and modified active assisted, like gravity assisted. You can consider that because one is active, one is passive. And breathing control is not an. If you see option 3, PEP is still a air clearance technique, but breathing control isn't.
Yeah.
Okay.
Okay. So the next one is, which of the following statement about the mercury mask is true? A. It is used for the delivery of oxygen for patients with hypercapnic respiratory drive. B. The high flow of oxygen entrains a small volume of ambient air. C. A fixed fraction of O2 can be delivered to the patient. D. It can be used for the delivery of the patient's inhaled medication. And E. Carbon dioxide accumulation in the mask is prevented by periodically removing the mask.
mask. Tulsi, you have a like, is it a 2005?
Yes, it's there, and also it's also given in crop file.
Crop file, yes, yes. Tulsi, can you just post that reason for it, please?
There is one. Okay.
Okay. Thanks.
Can I go next?
Yes.
Okay. Which of the following represents the lowest risk factor for IHE? A. Cigarette smoking. B. Stress. C. Family history of ischemic heart disease. D. Hypertension. And E. Diabetes mellitus. So what's the answer for this? B or E?
That's stress.
Yes, stress. Okay. Next one. 70-year-old male with COPD referred to an outpatient pulmonary rehabilitation program can walk up to 100 meters before having to stop due to breathlessness. Lives in ground floor unit. His lung function levels are FeV1.5, FeV1 FVC ratio 35%, resting oxygen saturation, some voice coming on, saturation 90% on air. Previous medical history includes right total hip replacement 4 years ago, gout affecting the feet and ankle. So can I go to the question?
Yep.
Which are the two most likely pathophysiological cause of the patient breathlessness during exercise? A. Airflow limitation, respiratory muscle dysfunction. B. Decreased chest wall compliance, decreased lung volume. C. Decreased lung compliance, decreased venous region. D. Increased cardiac afterload, peripheral muscle ischemia. And E. Increased cardiac afterload, decreased venous region.
Tulsi, can you post the answer?
Yes,
I'm sure there's a
I'm doing that. I'm doing that.
Yeah, I'm sure this is because we have done an APTA. I even have not sure about the answer. Guys, I was sure because it's not a cardiac problem. So yes, so Poonam, what do you mark C? I was likely to go with C because it's not a cardiac understand it's a respiratory problem. So I was confused with A and B.
Okay. The next question is already up.
Okay. Before prescribing an exercise program for this patient, which of the following test or assessment would you consider to be the most important to perform? A. Ability to walk upstairs. Incremental upper limb ergometry test. Upper limb strength. B. Chronic respiratory disease questionnaires. Shuttle or 6-minute walk test. This patient's use of walking aid. C. Airflow limitations using peak flow meter. Pulmonary function testing. SF36. D. Use of pulse treadmill protocol test. Strength of quadriceps and hip abductor muscle group. And E. COPD self-efficiency scale, COPD coping scale, and alcohol consumption. What's SF36?
That is
It's a psychological questionnaire, na? Short form 36.
yes. Everything is included, physical activity and psychosocial participation.
So the answer is B, is it, for this one?
Yes.
Hello, I was saying that my mic off. Guys, like how ACPT is a very good technique there for the airway clearance. So whenever you see 6-minute walk test, always go for that.
Yeah.
They emphasize on 6-minute walk test. So wherever whichever option 6-minute walk test, please take that.
Okay.
It's clearly given in pulmonary.
Yeah. They always have
Always follow the physical.
Can I go to the next question?
Sure.
All of the following techniques will help this patient to recover from the breathlessness after walking, except A. Pursed breathing. B. Forward leaning positioning. C. Fixing the shoulder girdle muscle. D. Thoracic expansion exercises. And E. Breathing control.
It cannot be C. If you fix your shoulder muscles, that is, if you practice unilateral exercises, elevation exercises, you do have a stability. And thoracic expansion exercises will never help you. It's a kind of I think more of lung expansion exercise. It's not breathing relieving technique. Sorry, dyspnea relieving technique.
Okay. All right. Thank you.
So it's the D, yeah?
Yeah. This kind of questions were repeated earlier. Remember, we had which is the dyspnea relieving position for asthma. Some patient of asthma.
Yep. I remember.
Yeah.
Okay.
Next question.
Yep.
Yeah. While supervising the patient's rehabilitation program, the therapist becomes concerned about the accuracy of pulse oximetry reading. Which of the following statements about pulse oximetry using finger probe is false? A. Peripheral vasoconstriction may give an inaccurate reading. B. Motion artifact may give an inaccurate reading. C. Pulse oximetry will be accurate even when the pulse is irregular. D. Optical interference may occur if the reading is taken in a room with bright ambient light. And E. Inaccurate reading may occur when values are very low, below 80%.
So answer is C, is it?
Yes. In crop pile it is given that when there is a very low value of oxygen, there may be fault really in the proximity. Oxygen saturation curve is given in oxygen saturation curve.
Tulsi, this is again a
Yes, I put
2005 question.
from there only I put.
Okay.
The answer is B.
Yes, answer.
Okay. Next question. Which non-invasive test can be used to quantify the strength of respiratory muscles? A. Force vital capacity, comparing values in sitting and standing. B. Fixed inspiratory and expiratory mouth pressure. C. Positive expiratory pressure mask. D. Chest radiograph. And E. Pulse oximetry.
Yay! Yes.
So is that a B?
It's a B.
Yeah. Okay. Okay. Last question.
Yay.
Which, yeah. Which of the following about the effect of pulmonary rehabilitation program are false? 1. An increase in maximal workload occurs. 2. Oxygen consumption for a given workload is decreased. 3. Improved self-confidence reduces patients' anxiety about exercise. 4. Reduced ventilation is required at a given submaximal workload. And 5. Resting heart rate is reduced. So the answers are maybe A 1, 2, 3, B 2, 3, 4, C 2 and 4 only, D 3 and 5 only, and E 1 and 5 only.
But what is the
It's E. Tulsi has put a nice reference there. Guys, okay?
Yeah.
All right. So what are we guys doing tomorrow?
What time actually we do tomorrow?
Same 8:30. 8:30.
There's only one question paper is left that given by answer. So just search out any different questions are there, and let's solve that only.
Tomorrow. Is it okay? Let's clarify which paper are we talking about? Is it that paper where the first
Yes.
the
So
first question is Mr. A is a 80-year-old retired man of the farm? Is that the one?
yes.
Okay. So yeah, we can do that tomorrow. Let's do that.
Just everybody read the questions because there are so many questions we already solved. So we will solve the different question only.
Okay.
Because
Sounds
there are so many questions.
Sounds good. Acha, I'll post it once we're done. The one, remember Komal, it was the one which Esther has posted for us. It's got a lot of pages. It's got about 83 pages.
It's APTA. It's APTA 1.
Yes. It's chapter one.
It's APTA.
And Tulsi, can you post this other question paper, the 2001, which you?
Sure.
Yeah. Thank you so much. and I can repost Miss Esther's one. Okay?
I'll post on FB.
Yeah, we'll post on FB. Smartha, you have exam
What
tomorrow,
time
right?
are we meeting? 8:30?
Yes, 8:30 p.m.
Yeah,
What time is your exam?
10:40.
And Heli, you have later, is it? Is it different time?
I have in the morning from 8:30, but the thing is, I have speaking very late, like at 5 o'clock.
Oh.
So I have to wait for 5 hours for 10 minutes speaking.
Oh dear me. Okay. Yours? What about you, Smartha?
My exam starts at 10:40, but my speaking is at 4 o'clock. But then again, they say that they'll tell you only when you reach there.
Oh.
It's usually on that time. It's usually because last time I had at 1:25, but it was on sharp 1:25. So it will be on sharp time.
Oh, have you given this exam before?
Yeah, I missed reading only.
Oh, that are you able to finish your 15-minute thing? I can never finish the answers in 15 minutes.
That's what I told you. I missed reading, so I got B in all the other sections, but I didn't get. I got C in reading.
And how is speaking? Is it easy?
Oh, speaking is very nice because it's only doctor, physio, patient conversation, so it's very nice.
I'm so nervous. I'm seriously nervous because I've never given this exam before.
Oh,
In the reading part, some of say that if you cover 12 to 14 questions on average, and then you do well in your second part, then you have good chances of clearing this.
yeah.
Like I'm trying so hard to finish and it's ridiculous, man. I don't get it why they have to take the paper away in 15 minutes.
Yeah,
And we don't need 40 minutes for the next two parts at all.
You know, I'll tell you my last experience. In last reading, like the 15-minute one, we had that summary, which is saying that nearly 6,000, and they are giving in the question they give the value 5,400 and 5,600 and something. So I was looking for 6,000 everywhere. I was looking for 5,000 everywhere, and then I found that nearly 6,000. So nearly 6,000 means 5,640. Yeah. Yeah. So I was looking for 5 minutes for that thing.
Oh my
Yeah,
God! Such a waste of time.
yeah. Or in within 15 minutes, you just have to spend 30 seconds on each question.
And most frustrating part is, they keep on saying that 5 minutes left, 2 minutes left.
Yeah,
So frustrating.
and even while listening, you just have to focus on the speakers. Not they are not providing any headphones for this.
No headphones. Yeah.
Yeah.
And in speaking, if you've given IELTS, it's very